Tomasa is a 17-year-old, history of VP shunt placement in 2000 for hydrocephalus related to prematurity, who presented to Texas Children's Emergency Department 2 days ago with slurred speech, right arm numbness, and right-sided face numbness and tingling. Patient reports the tingling has now resolved and she was able to talk. However, she felt as though she wanted to talk but couldn't. And mother reports it was difficult to understand her speech due to it being slurred. Reports tingling on the right side of her body and slurred speech lasted approximately for 30 minutes and then resolved. Patient does also report headaches and fatigue over the past six weeks. Reports the headaches have occurred nearly every day over the past 6 weeks and have usually been associated with nausea and photophobia. Reports headaches are periorbital and retroorbital in location. Reports locations are not affected by position changes and do not wake her up at night. Reports headaches do not usually have an aura associated with them. Reports headaches have, however, improved with over-the-counter Excedrin that she has been taking. Denies any recent fevers. Denies vomiting or diarrhea. Denies dizziness or confusion. She does report, however, mild blurry vision intermittently, but reports she probably needs her eyes checked since it's been a long time. Denies any recent head trauma or injury. So as reported, this patient has a VP shunt that was placed in 2000 for hydrocephalus related to 29 weeks prematurity. Patient has not had any follow-up or monitoring of her VP shunt or any health other than vaccines received from the health department in the past 10 years due to mother not having health insurance. Patient has not had any prior shunt malfunctions or revisions in the past 17 years. Denies personal history or family history of headaches or migraines. Patient has had her vision checked at school, however has never had her vision checked by an optometrist in the past 17 years. Denies history of seizures or family history of seizures. Denies history of TIA and denies history of hypertension. Reports prior to hospitalization for prematurity and VP shunt placement required a 4-week NICU stay for prematurity and a total of 5-week hospitalization after birth. Patient has not required any other hospitalizations or surgery since this time. The only surgery reported was the VP shunt. Denies any daily medication. As reported, patient has been taking 1 Excedrin PRN for headaches as needed. Allergies to Bactrim. Her immunizations are up to date by the health department. She does live with her mother, aunt, and cousin in a suburb of Houston. She denies any smoking or alcohol or drug use. So upon presentation to the ED, patient was alert and oriented. Slurred speech and reported numbness and tingling had resolved. Sensation was intact. She was afebrile and vitals were stable. Her face was symmetric, equal muscle strength in all 4 extremities, 5 out of 5. She currently was complaining of a periorbital headache, however, she was neuro intact. Due to the history of VP shunt and symptoms, a head CT and shunt series was ordered. The head CT was difficult to compare since the last one was ordered over 15 years ago. However, it did show enlarged ventricles, but decreased compared to 14 years ago. The shunt series, however, did display at least 2 areas of disconnection or breaks in the tubing on the lower right side of the neck. Due to the findings, neurosurgery was consulted and the patient was admitted to the neurosurgery service. CBC and coags were ordered. So as reported, patient was admitted to the neurosurgery service where she was taken for surgery that evening for a shunt revision. New distal tubing on the shunt was placed from the head to the abdomen. Patient did tolerate the surgery well and was transferred back to the neurosurgery floor for observation and management. Patient was started on cefazolin IV 30 milligrams per kilo per day every 8 hours and Docusate and Urelax for stool softeners. Tylenol every 4 hours PRN was scheduled for pain, and the reported labs that were obtained prior to surgery, the CBC and coags, were all within normal limits. So patient is 61 kilos, her vital signs, heart rate 78, respiratory rate 18, temperature 98.6, blood pressure 107/94, and 100% on room air. Her exam, she's currently reporting pain at the incision site on the right side of her abdomen, otherwise denies any headache. The patient is awake and alert, lying in bed upon assessment, no acute distress, able to converse. Her head, normal cephalic. She does have mild frontal bossing. Her VP shunt is palpated on the right side of her scalp and along the right side of her neck with no swelling or obvious fractures in the catheter. TMs are normal. Her nose is clear, no rhinorrhea present. Her mouth, moist mucous membranes, no erythema or exudate or swelling, and normal dentition. Her eyes, conjunctiva without erythema or discharge. Pupils are round, equal, and reactive to light, and 3+ bilaterally. She does have full range of motion of her neck, a little tenderness muscularly on the right side of her neck from where the catheter was placed. Normal rate and rhythm and normal heart sounds cardiovascularly. Pulmonary, her lungs are clear, no retractions, patient is on room air, setting 100%. Her abdomen is soft, non-distended. She does have mild pain with palpation around the incisions on the right side of her abdomen, otherwise no pain in the right lower quadrant. Musculoskeletal, she does have short stature and limbs are noted. She does have normal range of motion of all extremities, no swelling or deformity. Neurologically, the patient is alert and oriented ×3, symmetrical facial movements, sensation is intact. She follows all commands appropriately, intact reflexes, and she does have a steady gait. Skin is warm and dry. She does have 2 right-sided abdominal incisions with skin glue intact. No drainage or swelling or warmth is noted, and she does have a peripheral IV in the right anicule. So problem list for her is health maintenance, VP shunt malfunction, headache, nausea, and risk for infection. Differential diagnosis, VP shunt malfunction, a brain mass, seizure, a TIA, or migraines. So the impression of this patient, a 17-year-old female with headache and nausea for 6 weeks, now with an episode of slurred speech and numbness and tingling to the right side of the body. CT findings show mild enlarged ventricles, however no acute concerns compared to the original one. And the shunt series does show the 2 areas of visible disconnection of tubing in her neck. Patient has been afebrile and vitals have been stable. The recent headaches and neuro symptoms of slurred speech and numbness tingling are most likely related to her recent shunt malfunction. Symptoms did resolve after patient was taken to surgery for shunt revision. She is stable at this time and will continue to monitor neurostatus, pain control, and risk for infection. The assessment and plan for this patient, we did consult ophthalmology and an ocular exam did show prior to surgery a grade 4 bilateral papillary edema prior to the shunt revision. Consulted neurology to evaluate for possible seizure activities. Consulted social work to help family manage health insurance and make follow-up appointments so patient could appropriately follow up and manage her health better. Continue IV cefazolin, 30 milligrams per kilo per day, every 8 hours until discharge. Patient will not need to be sent home on an oral antibiotic. Continue Docusate and Miralax and consider a possible suppository to make sure the patient is able to have a bowel movement without straining prior to discharge. Manage the patient's pain with Tylenol every 4 hours PRN. If worsening pain, may consider ibuprofen for 3 doses and then monitor for worsening headaches. Advanced diet as tolerated, making sure the patient is going to be able to tolerate PO prior to discharge. Encourage PO caffeine to help with headaches, and make sure follow-up appointments are scheduled for the patient prior to discharge to promote follow-up.